So now we are going to see about an important topic about the cervical cancer pap smear screening. So before we go further, I would like you to know the cause of cervical cancer. The cause of cervical cancer is human papilloma virus. The human papilloma virus 16 and 18 causes cervical cancer, and the human papilloma virus 6/11 causes condylomata acuminata. I have another video on it. How will it present? There is a transition zone in the cervix. So how will this transition zone be? We have the uterus, we have the cervix. We have the ectocervix, as well as the endocervix. Endocervix will be columnar epithelium, but ectocervix will be stratified squamous epithelium. The junction between the columnar as well as the stratified squamous epithelium is the transition zone. That zone is prone for squamous cell carcinoma of the cervix. So whenever there is a squamous cell carcinoma of the cervix, there will be intense vaginal bleeding, there will be very much purulent discharge, and if it progresses further, then it can even attack the surrounding structures, resulting in hydroureter, which can either be bilateral or unilateral. So this is what is the cause and the presentation. Now, to whom should we do a pap smear? The concept is that the pap smear should be done to the ages 21 to 65 years. But what is this concept? What if they have some discharge when they are less than 21 years? When they are less than 21 years, then we are supposed to do them check for the only sexually transmitted disease. Not pap smear is not indicated. Why? Because of the fact that the immunity, the very good immunity will cure the human papilloma virus, will fight against the human papilloma virus, and it will not allow to progress further in those who are less than 21 years. So if at all they have any symptoms, then they should be checked for sexually transmitted disease. What about, so to whom is the pap smear recommended? Pap smear is recommended for 21 to 65 years. Now even with that, we have some more subclauses. In 21 to 30 years, pap smear is done once in every 3 years. So how do you remember this? 1, 2, 3. So every 3 years we do pap smear. But in between 30 to 65 years, we have two options. Either the pap smear can be done every 3 years, or else pap smear, when it is done along with the HPV co-testing, then it is enough if we do it every once in 5 years. So this is because we have already checked for HPV, human papilloma virus. So it is not necessary to repeat pap smear every once in 3 years. So when co-testing is done along with pap smear, then it is enough if we do it once in every 5 years. Now we have some more clause. So how will a HIV patient present with? Now if a HIV patient if is diagnosed, they are already immunocompromised, and that case, so they have a higher chance for the human papilloma virus to attack them. Therefore, in HIV virus, if the patient is suffering from HIV, then in the first year, after they have detected, in the first year, pap smear should be done once in 6 months. That is twice during the first year. After that, it has to be repeated every once a year. So this is about HIV. Now what do you know about HSIL as well as CIN3? In those who had high grade squamous intraepithelial lesion or else cervical intraepithelial neoplasia 3 or 2, they have had it and then they have been treated with it. Even if they have been treated for it, we need to check by doing pap smear even after 65 years. Even after 65 years, pap smear should be done to check whether they are having a repeat CA cervix. For those who had CA cervix, and hysterectomy is also performed. Now what do we do? Even for them, even after 65 years, pap smear should be done to the vaginal vault to look if there are any changes. But if the hysterectomy is done because of endometrial carcinoma, in that case, pap smear need not be repeated after 65 years. So the general rule is 21 to 65 years. But after 65 years, to whom should we do pap smear? Those who had HSIL or CIN3 and when they are treated, and those who had a CA cervix and who for whom hysterectomy is done. So this is about the pap smear. Fine. Now let's see what if we do a pap smear for a patient and it presents with low grade intraepithelial lesion or else ascus. What is ascus? Atypical cells of unknown significance, atypical squamous cells of unknown significance. So in that case they are only low grade or else they are only atypical. So there are chances that it might regress on its own. So we have only two options. Either we can tell them that with the pap smear has to be repeated and then they can come after some time, or else immediately. But if the patient is very apprehensive and the doctor also doesn't want to settle with it, then or else we can do HPV co-testing. So once HPV co-testing is done, then we will have a clearer idea whether that unknown significance, that is we have some abnormal cells, whether it is really because of human papilloma virus. Therefore we check for HPV co-testing. Now if the HPV co-testing is negative, then we are relieved and the patient is also relieved and he can be discharged. But if the HPV co-testing is positive, then the colposcopy should be done. In the colposcopy, it is to visualize the transitional zone. The transitional zone is visualized and the biopsy is done in that area, so that we will be sure whether they have progressed to squamous cell carcinoma or what is the range. So this is about low cell as well as ascus. But what about high grade squamous intraepithelial lesion or the cervical intraepithelial neoplasia 2 or 3? So for them they are supposed to have pap smear is done and this is detected in that case. For them again they should also be subjected to colposcopy as well as biopsy of the transitional zone. Now we have another doubt. The colposcopy is done, but the transitional zone is not visualized properly. Colposcopy is a technique to visualize the transitional zone and then biopsy it. In that case, cone biopsy should be performed. If the transitional zone is not visualized, then the cone biopsy should be performed such that we can be sure what is happening inside. So once we have found out all this, now after that what is the next best step? Once the squamous cell carcinoma has been confirmed, then we are supposed to treat it. We are treating it with LEAP or else laser or else coning or else cryotherapy should be done. Now we have come to our final subclass, that is pregnancy. What if a pregnant woman is presenting with HCL, LSI or else ascus or even a high grade squamous intraepithelial lesion? If a pregnant woman has all these conditions, you should know that the pregnancy is an immunocompromised state. Therefore no intervention is needed during that pregnancy stage. After the delivery, she has to be closely observed if there is and watch if there is any regression, because the immunity has been regained after delivery. So if the regression is there, then no treatment is necessary. Otherwise the treatment will proceed as such. So I hope I have made this clear. I hope this helps you. Thank you.